Welcome back to Instagram Live with Intimate Rose. I'm Dr. Amanda, and I'll be joined today by the always extraordinary Andrea Martin. She and I will be discussing hormone therapy appropriateness for people with endometriosis. March is Endometriosis Awareness Month, and I am 1 in 10, one of those living with endo. So is my mom, and so is my grandmother. And I'm very passionate about care for people with endometriosis. Today, at the very end of our talk, I'll be sharing a code that will offer you 10% off of our tools and lubricants and balms at Intimate Rose, so be sure to watch all the way through. The code is good for 1 week, and every time Andrea and I go live together, there will be a different code, so be sure to tune in. And it looks like Andrea is getting logged in, so if you have any questions about hormone therapy, or any other questions for that matter. Hello!
I was just sitting here watching you talk, forgetting that I had to request stuff.
And you don't have jet lag to blame.
No, I'm just sitting here.
I'm sitting here enjoying me. Blah, blah, blah.
I'm here now.
I'm glad to have you and your clitoris background back on our show.
Oh, my girls.
All
My
your
girls.
girls. So, Andrea, today, our controversial topic, I mean, it's always controversial with HRT. I feel like we're starting to help spread the word about the safety of HRT for all of these different populations. Endometriosis is a tricky one because there's not even consensus within the field of endometriosis care, which spans from gynecology to urogyne to general surgery to disease processes all over the world. People are managing it in different ways. So we have a little tiny body of evidence. What do you think?
So let's get into it. I will just kind of review for people what endometriosis is. I feel like when people hear about it, if they know a little, it's like, oh, it's this like reproductive organ disease and it causes painful periods, and it's like the lining of the uterus grows outside the body or outside of the uterus.
No, endo is not endometrium.
Oh, I love that you have a snap brain. It is so much more than that. It is chronic. It is systemic. This is not something that just occurs, maybe near your uterus or anything like that. It's inflammatory. And the tissue that grows, it is its own little, I don't even know, it just marches to the beat of its own drum. It does not specifically respond necessarily the way that the lining of the uterus would. It just does what it wants to do. We don't, like you said, we don't fully understand it. We don't fully understand what causes it. We know it can occur in all genders, even though it is very rare in men. I'd say the most common symptoms that I see anyway are like really painful periods. Usually when I'm talking to a patient and they're just talking about their periods and I'm like, do you vomit when you have your period? And they're like, yeah. And I'm like, do you have to miss work or school? Because the pain is so severe. And they're like, yeah. Mm-hmm. I'm like, okay, that's not normal. We need to look into that. So many women are walking around just dealing with it and thinking that it's normal when their pain is off the charts. You'll see lots of pelvic pain, pain with sex, pain with bowel movements. The only definitive way at this point in time to diagnose it is via laparoscopy. So going in, taking a little biopsy of the tissue to confirm. There's no cure. There's treatment options, excision, so cutting out the endometriosis, but it can always grow back. You can always miss some. We use birth control. We use medication that kind of suppresses the body's hormones, and progestins, which we'll come back to because that's kind of a part of this whole menopause and HRT thing in endometriosis. So one thing about endometriosis is it's usually described as being estrogen dependent. But again, this is kind of an oversimplification because there's so much we don't understand. And you would assume, okay, if it's estrogen dependent, somebody goes into menopause, that's a low estrogen state. Great, endometriosis, done, gone. But that's not the case. one study I read said 2 to 4% of postmenopausal women will have a continuation of their existing endometriosis or even new endo. And I just have to assume that that number is lower than it actually is because our research for endometriosis in the first place stinks. And then our research with menopause in women stinks. So I'm missing some people there. So in menopause specifically, there might be kind of, when we're thinking like, well, why would this still progress? Why would this disease still be there? Some of the reasons might be that the little endometriosis deposits can actually manufacture their own sources of estrogen. So they use fat and something called aromatase, and they can convert testosterone or androgens into estrogen. Possibly could be stimulated by what's called exogenous estrogen. So basically estrogen that's not made by your own body, something that you took, maybe HRT. And then it also develops progestin resistance. And in premenopausal women, we use progesterone, progestins all the time to kind of counteract like the growth promoting factors of estrogen, and it's anti-inflammatory. But we don't really know if it acts the same way in postmenopausal women, since its primary mechanism of action is to counterbalance the effects of estrogen. But menopause is a low estrogen state. So all this to say, it's all very confusing. So you would think, based on what I'm saying, like, ooh, it might not be a good idea. I don't know. It is. Hormone replacement therapy is absolutely not contraindicated in patients with endometriosis. We do it all the time. I have plenty of patients on it. They have no issues. One thing to keep in mind is when you're going through your regular cycles before menopause, you've got those peaks and valleys, and you're getting much higher levels of estrogen than, say, I throw you on a low dose estrogen patch. So at the highest point of your estrogen production in your cycle, maybe you're at like 500, 600. If you're on hormone therapy, we're seeing levels, between like 40 to 100, so like much less. I would say that sometimes how we approach this, again, we don't have guidelines. There's no like definitive way, like you should do this and then your patient will be fine. But a lot of times patients with endometriosis end up with hysterectomies because people think that's going to make it all go away, and it doesn't. But anywho, the basic premise when you take hormone therapy is if you have a uterus and you're taking estrogen, you have to take progesterone to protect the uterus. So a lot of endo patients don't have a uterus, but sometimes we'll just use a progestin anyway. Case that might be helpful in suppressing any remaining endometrial tissue. I think our newest option and probably best option is this medication called Duvet. And it's a combination, it's a pill, so you take it by mouth. It's a combination of equine estrogen and basidoxifene, which is a medication called a SERM, or selective estrogen receptor modulator. So it's kind of like magic. It can, certain areas of the body, these SERMs can like promote estrogen, and other areas of the body, it's anti-estrogen. So this happens to be very antagonistic to endometrial tissue. So this might be a good option for patients with endometriosis who want relief from their hot flashes and want to protect their bones and all the things, but are really afraid of, stimulating their endometrial tissue. I actually saw a couple studies, or I don't even know if they're studies or case studies, where they were using the Duvet in premenopausal patients in combination with other medication to help with endometriosis symptoms. Bottom line, you get to decide. I think most people with endometriosis would do just fine, but I'm never going to be the one to say, like, this will not cause an issue in anyone. Like I said, we've got that 2 to 4%. And as I said, I'm sure there's more people than that continue to have endometriosis symptoms past menopause. I see one person said, what is HRT? Sorry, hormone therapy. So that's the medication that we give to women in perimenopause, after menopause, to help with symptoms like hot flashes, night sweats, protects bone health, heart health, all the things. So bottom line, you can do it. We do it all the time. Very small risk of issues with your endometriosis.
And another transition of nomenclature is to menopause hormone therapy. Do you know the new medication that you just said, is it acting on the pituitary gland or is that acting on the ovaries? Like, do you know where that medication is acting?
Like the serum part of
Yeah.
the base, it acts on, well, it specifically acts on the uterus itself, but then it has pro-estrogenic effects on like the bones, the heart, I believe the hypothalamus. I could be making that up. But yeah.
Excellent. And one other thing I wanted to point out with regards to lap procedures is excision surgery is the only means of truly structurally managing it. Time and time again, we see ablation doesn't work. But another issue that we run into with management of these patients is that not all surgeons or gynecologists or people performing the laparoscopic procedure know all of the variations of how endometriosis can present. It can present with different colors and different infiltrations in different locations. And so it's really important to see someone that specializes directly in endo and they've made a whole career out of endometriosis. So they're very trained. There was a really interesting it wasn't a study, it was more of like a little bit of a test at a conference, and it was something like 80% of the physicians did not accurately recognize endometriosis when presented on a slide. So that means the person going inside and doing laparoscopic procedures might see something and not understand that that's endo and breeze through it and leave it and move on. And so then your endo isn't really managed. And then as you go through age-wise, coming to this precarious point of life that is perimenopause and menopause, where things can get really wonky and we see those valleys and those peaks like you described that can make it worse when we're expecting it to get better, because goodness knows we've paid our dues for the last 40 some odd years. So that makes it really challenging. So it's really lovely to hear that for many people, hormone replacement therapy is going to be not only safe, but could provide some stability to some of those symptoms. So that's good news for the endo population.
Hey, you.
Yay.
I have a patient who's had like pretty severe endometriosis. But it's funny at this point, she's like, I don't care. Like, I know we don't necessarily have all the research for this, but she's like, these hot flashes gotta go. This, like, she's like, I'm comfortable with this decision. No matter what happens, like, just give me my hormones. Like, you get your hormones.
You get your hormones. Yes, absolutely. And I think too, like the whole concept of the estrogen only versus the estrogen and the progestin together, um, is a really important concept just in terms of like the safety, as you mentioned, because a lot of people do still have their uterus with endo. So also good to know. We got a question about, does dilation really work for MRKH? Yes, absolutely. MRKH is a different condition that we've done a lot of education here. I'm very passionate about it. I partner with a lot of wonderful providers for this genetic condition. And the research shows that 10 to 30 minutes per day for several weeks, slowly but surely yields increased length and width in the vaginal canal. For more information, you can visit our website, and I have other videos on MRKH and AIS here on Instagram as well. Okay. Can you be, oh, this is a really tough one. I know that a lot of I'm going to read the question, but I just want to preface this. I have a lot of surgeons and physicians in the space that are very opposed to certain medications. This question is one of them. Can you be on Orlisa during perimenopause, or what's the best time to stop using it? So I just want to preface with say, like, I have colleagues in the endometriosis space that don't necessarily agree with the medication Orlisa. So it is a controversial one. I just want to acknowledge that. But this person is specifically asking, can you be on it during perimenopause?
I don't know. I don't know. I don't visit any of my patients that I'm like, I think you might have endometriosis, like you said, I send them to the very specific endometriosis specialist that this is all they do day in, day out. And then let's work together. I mean, the basic premise when you're on a medication like that, a lot of times it's kind of putting you into like a fake menopause in a way, estrogen levels. So, I mean, yeah, I don't know. I I don't know if it would even make any difference once you're in menopause because everything's already shut down. But I know there's a lot of those peaks and valleys and craziness going on in perimenopause. But curious as to what some of the thoughts are on that medication, of like the controversies.
You're curious and you want me to say them out loud here on Instagram Live. I don't want to speak for my colleagues who are physicians, but they are feeling that it's not addressing the endo, so I would just encourage this person to speak with their provider, particularly the one that prescribed the Orlisa, about when they should stop using it, because every person is unique and every person is prescribed according to their complete medical history. So would just encourage you to have that conversation with your prescribing provider.
It's
Um,
all these medications, like the side effects, how it makes you feel versus like how much it actually does reduce your pain. And I patients maybe they do see a big difference, but for others it's almost like the journey you go through just trying to get relief ends up causing issues in other areas of life. So
yeah, juice not worth the squeeze in some cases, or not producing any juice at all.
thirsty.
That's right. The endo population is always. Okay, somebody, um, okay. If we haven't yet answered your question, it's possible that it happened higher up in the chat and we just simply haven't seen it. So if you want to type it in here, we are happy to answer it. Otherwise, you can always DM Andrea or Intimate Rose here and we will get a response to you. I do think we got them all. Yes, okay. All right, so if we didn't answer your question, please go ahead and DM either one of us. We are happy to answer it. Our code for the next week for 10% off is ENDO, ENDO, and that will give you 10% off of our tools and lubricants and balms and wonderful things. And we are so thankful to have had you, Andrea. We have so much more to come. We will be back together here March 20th, where we'll be discussing HRT and reflux or GERD symptoms. And in the meanwhile, keep doing all the great things. And thank you so much for your expertise and your time.
Thank you, and thanks for sharing your little bit of your endo story with everyone. I think that's important.
Absolutely. And for other information on endo, I recommend following the Endometriosis Summit. Sally Sorrell does an amazing job. Ginger Garner is another pelvic health physical therapist who has lived the journey and is sharing a lot of information too. And just keep in mind that medications are so individual and so specific. So, there's different philosophies within this field. We're still learning and we're still growing a lot. So just because something's controversial doesn't mean it's not right for you and your prescribing physician has your best interest in mind. Just sometimes it can be helpful to get other opinions and to understand what the drug is truly intending to treat or manage. So there you have it. All right, Andrea, we will see you later.
Thank you.